Welcome to Reducing Risk, a series of podcasts from medical protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Our current series is focusing on demystifying the Medical Council standards, and today we're looking at the statement on resource constraints. It's a very hot topic at the moment, and through our MPS advice line we get calls every day about the medical legal risk of working in areas of resource limitation. Because of the breadth of this topic, we've decided to divide the subject into 3 separate podcasts.
It's a trilogy.
A trilogy, yeah, there you go. We've already done the first one looking at primary care, and now we're on to the secondary care system. And then our third one, which is our next one, is going to be on looking at how the HDC approaches issues that have arisen from areas where the services have been unduly stretched. So this is the second podcast, and we're covering issues of resource limitation in our hospitals. My name's Dr. Lucy Gibbard, and I'm one of the medical legal advisors at MPS. And today we're very lucky to be joined by Sarah Dalton from the Association of Salaried Medical Specialists. Say that right? Better known as ASMS. So hello, Sarah.
Kia ora.
Kia ora. And we also have Sean O'Sullivan, a partner at our panel law firm, Wood & Kearney. Hello, Sean.
Hello, Lucy.
And I'm also very grateful to be joined by my colleague, Dr. Chow-Yan Chen, who's another medical legal advisor at MPS and also an anaesthetist. So hello, Chow-Yan.
Hello, Lucy.
Before we start, I just thought it would be useful for Sarah to briefly tell us about ASMS and what you're doing within your role with respect to the under-resourcing in hospitals. If you've got anything that you would like to say at this point.
Sure. So ASMS, Toi Mata Hauora, is the union for senior doctors and dentists who are salaried, which includes salaried GPs. Lots of people think we only cover doctors and dentists who are hospital-based, but in fact we are there to support all salaried senior doctors and dentists. Yeah. So we advocate for our members in terms of their employment, their core terms and conditions, which we negotiate through our collective agreement. We also help to support our members when trouble finds them or they find trouble, sometimes in partnership with MPS. And we also have constitutional objectives to advocate for the best public health system that we can possibly have. So I guess a range of our functions hit on this business of resource constraints.
Absolutely. Yeah. I think that's really relevant to a lot of those aspects of ASMS, isn't it? So today, what we're going to go through is some examples, and hopefully using those examples, we're going to draw out some of the themes that where resource constraints can impact the care provided in secondary care services. We get lots of calls to our advice line, but look, in the interests of anonymity, this example is actually made up. I can assure you it's based on real calls, and probably some of the calls we have are even hairier than some of the things that we've discussed here. But if you think it sounds familiar and we're talking about your department, we're not. But we could be, But so this is basically made up but based on fact. So just imagine you're the on-call general medicine SMO for the weekend in a provincial hospital. You've been told earlier in the week that there was no registrar available for the weekend, so you'd have to be on call for the weekend with just your house officer. Now, that weekend turns out to be very busy, and the house officer is quite new and is unable to make any decisions independently. And you've been helping with admitting patients, dealing with sick patients on the ward, and you haven't had a break for 18 hours. The house officer has been replaced, but you're still the on-call SMO. At what point can you say this is not safe and leave? Chow-Yan, what are your thoughts on that?
Well, it's really hard, isn't it? But the reality is, if there are significantly unwell patients under your care requiring acute treatment, you can't just leave them unattended without making some arrangement for care, because we're all in it together and there's an entire hospital behind you.
Absolutely. So what should they do in that situation? What would you, if one of your members called you up in that situation, Sarah, what advice would ASMS be giving in that situation?
So ideally, they would have rung us before the weekend.
Yeah, that would help.
So that we could put some things in place before that weekend started, because unfortunately your made-up example is increasingly the norm in hospitals around New Zealand. So we like to get in front of things wherever we can. There are obligations in our collective agreement about what management is required to do to make things safe for staff, to find locums wherever possible. But there are big differences between acute and planned care. So look, there are some things that could be done prior, including the SMO group sitting down and working out what they believe is safest and most reasonable under the circumstances. And then ideally management will listen to that clinical advice and abide by that to the extent possible. But assuming that hasn't been able to happen and you've been there for over 18 hours and you're absolutely knackered, you're fatigued and you feel like you need to stop, then you should notify. There are always on-call executive staff, so they need to be notified to say, I no longer believe I can safely work. I need support for another senior medical officer to be found that can come in and oversee. So, some services might have second on call, so it might be as simple as being able to call a colleague to say, I'm really sorry, but I need you to come in as second on because, and ideally also there will be sleeping accommodation in the hospital so that you're not required to drive home unsafely.
That's a good point, actually, isn't it? There's no point going home and having a car accident on the way home, is there?
If you're that fatigued, you should be resting before you go home, or transport should be provided. We're actually working with Te Whatu Ora on some fatigue initiatives at the moment, and the first of those is safe transport home for anyone working at night. We already have a provision for SMO sleeping accommodation. It's been in the Mecca forever. Most hospitals don't provide it. It's a massive concern, and we are going to be taking compliance actions in the coming months.
That's interesting. So basically, for our poor doctor that's been working for 18 hours, if he or she feels that they're no longer able to carry on, they're not providing safe care for their patients, actually they should notify management and maybe colleagues, and try and get someone to take over rather than just walking out. Is that what we're saying?
Oh, no, you absolutely need to let people know.
Yeah.
But you absolutely do need to stop, because anyone who's familiar with fatigue research will say that the most fatigued people are the least able to assess their level of fatigue. So you're probably more fatigued than you think you are at that point, if that makes sense. So, but it's incredibly important that you're not seen to be abandoning. The problem with, acute care, as you will all know, is that once patients are in front of you, you have obligations to those patients. Before they arrive, it's possible to set barriers and limits in place around what care may or may not be provided, around how many beds are open, how many people are able to be seen. The frustrations in planned care are different and can be managed differently, although they often come into conflict in hospital settings. But it is often what we hear from our members who work in acute care settings. What can we do? There are still patients that need to be seen. And unfortunately, that is leverage that the employers have and they use, and they put it on individual clinicians' shoulders. All of the things in our collective agreement and in our advocacy are trying to take those stresses off the shoulders of individual clinicians. Doctors already have enough decisions to make, life and death decisions. Without that, the organisation should be shouldering those responsibilities and speaking publicly about the extent to which there are resource constraints and how that might impact people's experience if they or a loved one turn up in hospital.
Sarah, just my question from me, what do they do to document that? I mean, what do they do to record? If this incident arises, would that be something that ASIMS would do for the person, or should they actually record what happened so that they have it on record that event occurred? How would you formally record it?
Look, I think the fact that you're probably going to be phoning someone up on your mobile phone means there's a log that a call took place.
Right.
In terms of notes, given that you're fatigued and you've already been out for 18 hours, you may or may not be able to make notes at the time. But I think as soon as possible afterwards, if you have any concerns at all, just note down your understanding of what the exchange was, or what the agreement was reached, or what the request was that you made. And then I would say, if you think there are medico-legal implications, or you're just not sure, you can contact MPS or just ring your ASMS industrial officer after the weekend to have a chat and say, hey, this happened, this is what I did, what do you think I should do? Do I need to do anything else at this point?
Yeah. It's really important what you said about trying to get in front of it, because all hospitals will have systems that kick in these terrible situations where there's no one available. And if you're exhausted, then you've got to consider whether the service needs to close. And hospital systems do have these levers, if you like, where if there's no one to run the system, it can close and the hospital goes on bypass, or the ambulances are notified. The patients that are already in ED, you're right, they're there, so someone has to look after them. But if it's, for example, general medicine on call, general surgery on call, then the ambulances are notified about them. The primary care GPs are notified, so that referrals go to your nearest hospital. The ambulances will transport those patients to the nearest hospital, and your hospital goes on bypass.
It works if you've got more than one hospital in your province.
That's
It's
right.
really hard if you're
That's
in
right.
Southland or in,
And they're hours and hours
where
away.
you've got hours and hours away. So I think, so the pressure becomes on the individual knowing that. So I think that it is a very good point to get ahead is a really good idea.
Yeah.
I think also the idea of recording when actually not, when you've had a shift where you felt it's been unsafe, to write that down somewhere. I mean, we have HDC cases all the time where the doctors look back and think, that was a crazy night. We had all these arrests, we had all these emergencies, and yes, this thing happened, but in the context of what that night was happening, it's pretty understandable. But actually, the complaint doesn't come until 6 months later, and you can't exactly remember what happened that night. So I think having something recorded is actually quite useful for the future if there was a complaint.
Yeah.
So that you actually know what actually happened that night.
Yeah, some doctors will write, called away to emergency during this consultation, just to make a note that they were called away, so then perhaps the consultation was interrupted or didn't flow as well.
Mm. Can I just say there's a lot of pressure on doctors and services never to close.
Yeah,
that's right.
Absolutely.
But there are contingency planners in every hospital. That is their particular area of expertise. And I know at a small regional hospital recently, there was a decision made that most likely they were going to have to close acute admissions after hours because their medical staffing, it was a gen med ward, had become so low and so critically understaffed. And that was going to mean transporting patients quite far away, because actually the next hospital that was about an hour down the road was also a bit stuffed. So it has significant implications for patients and their families. But we need to make these things happen in a realistic way. We shouldn't be leaving it on the shoulders of one or two, the last doctor standing.
The last doctor standing,
That's right.
exactly.
Because the career implications for those people when something almost inevitably is going to go wrong in a situation like that are devastating. And you all know that just the time it takes to review these things, even where no fault is found to the individual in the end, the damage is already done in the trauma and the time it takes to unpack all of that. Where clinicians say these services are going to have to stop, we're on a countdown within the next week or 2 weeks or month, make your plans now because this is stopping. I think we would all be better off if people actually signalled that more often and more proactively and more boldly. Doctors need to hold hands, support each other to make those calls. They know it is in the best interests of services longer term, because if we don't do that, it doesn't wave the flag to the funders and planners who are increasingly used to routinely underfunding these things. The fact that we have to do these podcasts, yes, practicing medicine in resource-constrained circumstances, okay, but that shouldn't be business as usual all of the time and, look, it's got a little bit worse, a little bit worse. We need to be a lot noisier to stop podcasts like these being the last bastion,
It's interesting, though. This scenario goes on and this doctor doesn't leave. He's very exhausted. However, he stays and he reviews a patient on the ward, doesn't do a very good job, doesn't check the chest x-ray, patient later dies, like you say, the bad thing happens. What do you reckon? Is this doctor who's been working for 20 hours by now and has made a mistake, is he going to be held responsible for that?
Typical lawyer answer is a yes and no, isn't it? And it comes back to Sarah's point, is that the problem is that that doctor will be forced into a process. Now, whether it be a coronial process, which is terribly time-consuming and stressful, or an HTC process, then there's no way they're not going to be caught in that if a complaint is made or if an inquest is held. The HTC, the coroners are aware of the resource constraints, and they will put that in a mitigation context, but it doesn't take away the angst and the time-consuming coronial process from the doctor. The second thing is that the HTC Act specifically provides that if the doctor's taken reasonable actions in the circumstances, and I'll come back to the word in the circumstances, to give effect to the rights and to do a good job, then they're covered. And in the relevant circumstances, resource consents are there. The problem is that the code also makes it the responsibility of the GP or the doctor in this situation to prove that they have taken reasonable steps. So the onus comes back on the doctor. So there's, in a sense, an assumption of breach, but it can be disproved. And that's where your notes, and that's where the recording, and that's where everything then comes in. And I'm sorry that I sound like a broken record with you have to have notes, but where all of that is documented, then you're in a much better position to take that onus on and to show that yes, it was a constraints issue. In this situation, obviously very clear. Some of them aren't so clear, and there are shades of grey.
So that's why you've got to document your conversation with the on-call executive management, that you've discussed X, that you've discussed you're really exhausted, that you need to close the service, and note all of that down, so that then the hospital cannot say that they were not aware.
Yeah, absolutely. And having that in writing for the HDC case is helpful, if not totally mitigating. So moving on, we're going to look at another scenario where the hospital's just lost their only ENT surgeon, and the general surgeons have been asked to cover acute ENT cases without additional training or remuneration. They've been told, though, that they can ring the tertiary centre for phone advice for ENT, but they may still be left in a situation where they're going to need to do look after those ENT patients and potentially do ENT surgery where this is not something that they've routinely done. How about in this situation? You know, there is no ENT surgeon, so it's them or nobody. Are they going to be held responsible if there's an adverse outcome? What's the level that they're going to be held to in that situation? Can they say no?
Yes.
Yes, they can say no.
Well, I just want to, you mentioned no more remuneration and no other arrangements. That's a breach of our MECA. So again, I would say people generally know when someone's leaving. It's also not uncommon for the employer to do nothing or apparently not much about it, or say, oh, we're trying really hard, but we can't find anyone, blah, blah, blah. So first of all, there's two lines. One is about scope, and I will defer to my colleagues on that. But in terms of we want you to do extra as a group, and in particular something extra that you don't usually do, no way, Jose, without other arrangements being put in place first, including remuneration. But I take, that's not the most important thing in this discussion, but it is an important thing. Yeah,
and I agree. I think if it's out of scope, you're quite entitled to say no. And to answer your question, I think if you then decide, well, no, it's an emergency and I just feel I have to do it, I think you would only be held responsible to you're not going to be held responsible to the standard of an ENT surgeon. I mean, I think they would look at you and go, well, okay, fine. How well? What is the standard of care? What can we expect? It's a difficult situation because I've never come across it in that way before. But I don't think you could be held to the care, to the extent of the care, given the emergency nature of it. I don't think that higher standard of care could be applied to you.
So that's an LPS type of a situation, isn't it? That in the time it would take to transfer this patient, they might die. So in that case, a general surgeon is better than no surgeon at all. That's no disrespect to general surgeons.
That's right.
Correct.
And we've had cases before where, for example, there was no interventional cardiologist present in a small hospital, or no vascular surgeon, and the clinicians available were emergency providers, and they had to do, this was a cardiac tamponade case, I think, so they drained the tamponade. So they were the only people available to do it in that situation. And certainly in this situation, we talked about staying within scope, but the reality is it's a life-preserving service. So you work with whoever's available in the hospital together who provide emergency services, and you might have to do some simulations, you might have to go through those skills so that if you had the patient in front of you who really needed something, for example, a tracheostomy or cricothyroidotomy, then you've gone through the thought process and gone through the drill to provide that care. And it's so important that everyone in hospital is on the same page, because that's the worst situation is if someone shows up and you go, oh, well, we need the ENT surgeon, and people aren't aware that we don't have.
Yeah, so I think
ENT
planning
surgeon.
is really important
Absolutely.
for that. And yeah, upskilling is an option.
Yeah.
But I think even if you're upskilled, if you're still a general surgeon.
That's right.
And actually, I think it would be reasonable to say that you don't feel competent to do that, but hopefully upskill so that if there's an emergency, because we all know in an emergency you actually have to help to the best of your ability. But in
That's
that
right.
situation, you would only be judged at the level of a general surgeon doing their best,
That's
rather
right.
than be judged by a level of what an ENT surgeon might be able to do in the same situation.
By
So-
your peers, not
Yeah.
not an ENT surgeon.
Can I just pick up on the point about skills and simulation training, though, because I suspect they're some of the things that disappear under the deluge
Oh, of course.
of acute demand. And certainly something our members say to us is we're worried that we're not giving the quality of teaching to the RMOs, let alone to each other, in terms of, because in order to do those kinds of simulations outside of your scope, or
Yeah.
that's going to have to bring together people from a range of teams, I'm
Yeah.
thinking, which is quite demanding of time and availability, and increasingly that's a luxury in hospitals. So again, I think that's one of those things that the wider public don't always appreciate, and perhaps senior management don't always appreciate how critical those drills, those scenarios, that planning,
Yes.
and the ability to remain collegial across services in those very high pressure situations. We sometimes get disciplinaries where someone is deemed to have been uncivil to a colleague, and often the setting and the context is they're under intense pressure. That is exactly the kind of thing where, so instead of being thanked for saving a life, someone
That's
ends up
right.
going
With a
through the
complaint.
mill because they, swore a bit,
Yeah.
or
That's
right.
gave someone
Yeah.
a nasty look,
Yeah.
or,
Yeah. Absolutely.
Yeah.
Simulations and those things do make a difference when it actually
Absolutely.
comes to the situation.
Absolutely.
If you've actually practiced it,
Yeah.
it does help to know what you're doing.
And you've really got to think about, like where you were talking about before, planning the in this situation, if there's no service, then people need to know, it needs to be communicated to the community. An example, many years ago, like decades ago, I was an RMO in Wanganui, and there was a time for about 2 to 3 weeks where there was just no obstetricians. And so at that time, we had to shut the service. Everyone knew about it, so the general, it's really not ideal, but the general surgeons drilled and learnt how to do an emergency caesarean section so that if someone presented in
Walked in,
labour,
yeah.
they could help and provide a life-preserving service. But not ideal, and for that time, the service closed. All labouring women were sent to Palmerston. So they bypassed Wanganui.
Yep. I think it's also important to remember that for members of Toimata Hauora ASMS, we have a speaking out clause. So if you have raised concerns, ideally you raise them internally first. You notify
absolutely.
management,
Yeah.
and you are aware, you and your colleagues are aware that nothing tangible has happened, no space is being made for these kinds of skills development or mitigations, and they're not talking about it, then we would probably argue you have a responsibility, but you certainly have a right under our MECA to speak out and make that public. And we will also support you to do that. So there are many circumstances where we have made sure that our members are safe for speaking out. And we can also help that happen in terms of supporting them in the media or raising it in the media ourselves on their behalf. And I think that's a really important enabling clause to make sure that the wider public understands the difficulties that clinicians face just providing what most New Zealanders expect would be a standard level of care in any hospital. And I don't think, that debate really does need to happen. Maybe another podcast.
Yeah, maybe another podcast. Because the next thing I was going to just briefly touch on was the issue of triaging of referrals into secondary care, which again is an issue where patients have an expectation of a service that is available, which isn't always match the reality of what the service available is. And my example here is regarding a patient with a change in bowel habit and a reducing ferritin, but actually not anemic yet, who's referred in by a GP for a colonoscopy, but doesn't have visible bleeding and doesn't meet the threshold for a direct access colonoscopy and is rejected. Patient is re-referred to surgical outpatients, classified as routine under their current volumes, and presents to ED 5 months later with an obstructing cancer, having never been seen. And what is the situation there for the responsibility of the triaging doctor, who clearly has been, there are thresholds that are, not ideal, but are real. And yet there are patients who are going to fall through the cracks. And clearly with MPS, there are complaints that we get where patients feel that the triaging process wasn't appropriate. From the patient's point of view, that's very understandable because they didn't get their appointment. But from the triaging doctor's point of view, they're weighing up, who they can actually see. So I don't know, Chayan, do you have any thoughts on that, on the idea of who's going to be held responsible for that triaging process?
Well, I know that all services do have this triaging process where a specialist goes through a pile of referrals and try and decide who can be seen or who needs to be seen. But as you know, that will depend on what's written on the referral, if there's appropriate clinical information. And also, we're bound by what resources we have. So we're told, if there's X number of appointments that we could have, or sometimes there's no available appointments for some conditions, like that are deemed to be, for example, elective, like a hernia, but it's so significant on the patient's well-being. So there's lots of issues to consider, and if the question is who's responsible if they've never been seen, and you did the triage, well, then there's lots of mitigating factors, like was there appropriate clinical information? Did you actually note down that they needed to be seen within X period, but they weren't? Or did you send the referral back to the GP? So I think it depends a little bit on what you wrote down on the referral.
Yeah, so how it was triaged, you mean? Yeah. How about letting the patients know what the wait times are? Because patients often get an urgent, semi-urgent routine, but aren't really aware of what that means. What has the triaging doctor or the triaging team, maybe we should say, got an obligation or even the right to tell patients what the wait's likely to be?
I think a lot of doctors want to, but are not able to, because you just have this piece of paper in front of you with someone's NHI and the clinical information, so that you've got no way of contacting them. So unless you phone them to say, I'm really sorry. I'm really sorry. I have a stack of 40 patients or 100 pieces of paper I have to triage, and your triage or your presentation means that we won't get to see you for 2 years.
Sarah, I can ask you that, because do you think the doctors do have the right to say we want to let patients know what our waiting list is looking like? Because it seems to me, I've had calls to MPS from doctors who are saying that management really don't want them to do that they don't want them to let patients know what the waiting times are.
So clearly my background is not as any kind of a clinician, right? The bulk of my training was about how to teach history and English.
Oh, right.
But both in my current role in terms of advocacy for senior doctors and dentists and in my experience as a patient and a family member of patients, I would rather doctors said, and I don't think doctors need permission to share that information with patients, because I think if you're treating the whole person and you're thinking about the context in which you are all in, it is, again, I'm very sorry to have to share this disappointing news to you, but current wait times for this condition are significant. You may not be seen at all. And I think, that's part of that whole inequitable health system, because that's the point at which you say, do you have medical insurance, or can you afford to pay to go private? Because if you do that, complex gynae that is not deemed life-threatening,
Yeah, that's
good luck getting seen for that.
Endometriosis surgery.
Yeah.
Just doesn't happen.
Hernias.
Hip joint replacements.
Knees.
Lots of people are self-funding now. It's absolutely an equity issue.
Yep.
But
all kinds of chronic pain-related
Correct.
conditions that may stop people working, that may cause them to have dysfunctional relationships or develop mental health complications.
But they're not going to get seen in the public system sometimes. No.
For a long time, but actually knowing that at least helps people make decisions and understand where we're at in the system. And I do not think that doctors should be routinely disempowered by being told you mustn't let on, we have to give people confidence in the system. Why would you do that when you shouldn't have confidence in the system?
I'm just wondering, Sean, about that issue of offering private, because I think it's something, I'm thinking about a case from a long time ago where a patient was on a public waiting list for a scan, actually, and when it later turned out to have something on that scan, said, why wasn't I offered a private referral? I would have paid if I'd known. Now, it's easy with the retrospective to say that. I don't know. What are your thoughts on that,
Look,
Sean?
I think that all options should be canvassed, and I don't think they should be advocated in the sense of you should be pushing people to private, but all options should be made available to the patient. So raising it as an option, I think, if you're concerned about the delays, then I think at least raising and saying, hey, there is an option for you if you want to investigate it, is entirely sensible and probably should be done. I don't know how other people feel about that, but I think that's part of just the range of options available to a patient, and yes, raising it is I think sensible.
I think it sticks in the gullet with lots of doctors,
That's
though, doesn't
right.
it? When you have a patient in front of you who has got resource constraints of their own, and you're saying the system's resource constraint, would you like to, try and get your care in a private system? It does seem very hard. But I think, Sean, that mostly the HDC expect that we will have offered that to patients.
That's
and that
right.
if we haven't, that they'll actually be critical that the patient wasn't given that option.
I agree.
I think, though, it's really clear, isn't it? If you know objectively, based on what we're seeing, you are likely to wait 6 months or 12 months or whatever for the scan that you need, or the specialist referral that you need, or the procedure that you need, that is objectively what it is likely to be. And I mean, there are some conditions in private you're still going to have to wait a bit, but often not. So I think it has to be laid out for people so that they know, and you shouldn't make assumptions about whether they can or can't afford, whether they do or don't have insurance. I think if you're going to give them as much option, as many options as possible so that they can make an informed decision, and you try and make it as plain English as possible. And I think if there starts being negative commentary about our public health system as a result, so be it, because that's the way it is.
And certainly I think most Te Whatu Ora departments or specialist departments are being told Well, they're aware of how long patients have to wait. So when they get the GP referral, and I certainly know that a lot of my specialist colleagues have let the GPs referring know that this is X weight for X condition, so that GPs...
It's quite a helpful. It's a helpful thing if that was standardised. Actually, wouldn't it be that everyone knew how long? If you've got an inguinal hernia, this is how long you're going to wait, or you're never going to get.
That's right.
Because actually, it creates a lot of work in primary care where you don't know, and if you knew that actually, no, we're not seeing any inguinal hernias at all. Don't bother writing the referral letter, but there's always a bit of an onus from the general practice point of view, thinking, well, I'm covering myself by writing the referral, so at least I've tried. I've tried to access that for my patient, but but equally, I think the expectations of patients need to be realistic, because I think it leads to lots of complaints when patients feel that they were expecting to get an appointment, or they were expecting to be seen for their hernia, and then they're not. They often get very critical of, oh, you didn't write the referral letter right, or there was something wrong, I've been discriminated against. So I think if we can actually help people realise their expectations of what is available, I think that will help in some ways with realigning their expectations as to what's possible and hopefully reducing complaints. So we've had quite a lot of talk and it's all been very interesting, but I think we can probably move on and just look over the issues that we've discussed. And I think when we're looking at resource constraints in the secondary care service, I think that need to prioritise equitably to those most in need and having good triage processes is very important. I think the other issue is that not making decisions alone. When your department has got problems, whether it's for covering planned care or for covering acute care, if you can do it with your colleagues, I think that makes you less vulnerable. And so trying to make sure that you do document any discussions and meetings and that you transmit and communicate, because that advocacy for your patients is really important. And if there are problems, medical legal problems later on because a service hasn't been offered or a patient has fallen through the cracks, the fact that you've tried to do something about it and that you can show that paper trail is also very important. And obviously talking to ASMS if you have got concerns and you need help with that advocacy, and talking to MPS as well. If you've got concerns, Chen and I are on the phone, or us or our colleagues, and we're very happy to talk to you and discuss how you might approach these kind of issues. And I think the bottom line is doing your best, and when you're not safe to practice, withdraw, and tell someone that you're withdrawing. And look, it's sad that we have to say that, isn't it? That there are situations where that is occurring. So thank you for listening to this podcast. I hope it's been helpful. Our next podcast will be covering the HDC cases that have arisen from issues with resource constraints, and we hope you'll tune in for that. We look forward to catching up with you on our next podcast, and please do subscribe and leave a review. If you'd like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org. So thank you very much, Sarah, for coming along. Very interesting conversation, and thank you very much, Sean and Chow-Yen.
My pleasure.
Thank you,
And
Lucy.
we'll see you all again next time.
Thanks.
Thank you.